Hi everyone, thanks so much for being here tonight. My name is Jessica Garris and I'll be your host this evening. And if you haven't heard my little spiel yet, I just want to say I have a few housekeeping things to discuss off the top here. This session is being recorded. We hope to post the audio online at a later date, so just keep that in mind. If you do have any questions during the presentation at all, please feel free to type them away in the Q&A section. It's just at the very bottom of your screen there. And don't be shy. If a question springs to mind, certainly type it in real time, and we'll address it at the end of Dr. Lau's presentation. And I always love good questions, so don't be shy about that. And there's also a discussion pod, and I can see people are already using it, so that's great. People are saying hi from West Kelowna, Lena's saying hi from Comox, Ron from Vancouver Island, Iris from Burnaby, so that's great. So if you have any comments, feel free to type and use the chat box. We don't moderate it, but as I said earlier, I always try to keep my eye on it. So tonight's presentation is all going to be about why good management is important and essential in the prevention of diabetes complication and what really happens in our bodies. And this webinar is generously supported by Janssen, Lilly, Novartis, Novo Nordisk, and of course brought to you by the Canadian Diabetes Association. And we have a lot of people attending tonight, so that's great. And with that, I'm going to pass it over to Dr. Lau.
Thank you, Jessica. It's delightful to be able to share the knowledge with all of you today. And our topic tonight actually is a question. What really happened inside our body in terms of diabetes? To answer the question, I would like to invite all of you to a guided tour, a free tour, and we will be visiting 6 different organs inside our body to know their structure and function. And hopefully by the end of the session we have a deeper understanding of what's happening in diabetes. Knowledge, as you know, is power. Knowledge gives us power to prevent, control, and finally cure diabetes. So our guided tour will start with the islet cell, which, as you all know, produces insulin and several other hormones. Then we springboard to the liver, which is a factory that makes a lot of goodies for it. And it has also to do with our glucose and fat. And again, then the third station that we're going to visit is the adipose tissue inside our tummy, which is for storage of excess food in the form of fat. Then we should know about the muscle, which burns glucose to give us energy so we can work and play football. And don't forget the gut. Now, in my younger days, when I learned biology, the gut is only for digestion and absorption of food. But in fact, it also makes a number of hormones, and we talk about a very important hormone that have a cell phone connection to the pancreas, the stomach, and the brain to instruct them what to do after the food comes into our body. And the final station is our kidneys, which work as a filter to get rid of the dirt, but don't get rid of a pressure item like glucose. So let's move to the next slide. Now, before we start our journey, let me tiptoe you over the history of diabetes. I remember when in my younger days, my history teacher often quote me, if you know the past, you will understand the present, and you even can predict the future. So I hope by the end of this session, all of us together can predict what is going to happen to diabetes in the next 10 years or 20 years for that matter. History of diabetes goes back a long time, 3,000 or 4,000 years ago. And the ancient history, back in the 1500 BC, in different old cultures, there's been record showing that, stating that there are people who pass excessive amount of sweet urine. The urine is so sweet that the ant is coming for dinner. Then throughout the Middle Ages, diabetes is considered to be a disease of the kidney. Well, obviously, you're passing so much water, it comes from the kidney. The Persian doctor have a way of curing the disease by, they send the patient to ride a horse, thinking that the galloping rhythm may massage the kidneys to pamper them so they don't have to work so hard. In Europe, the doctors offer their kidney tonics in the form of wine, opium, aphrodisiac, herbs, etc. and etc. In China, the Chinese physician is more aggressive. We have to purify your kidneys. No sex, no booze. Until in 1869, there's a German medical student using his new toy, a microscope, and he discovered there's a group of cells in the pancreas. You can see in this diagram, these little blue dots are the so-called islets of Langerhans, named after him. But he didn't know what it's all about, what the function is. And the right side that just pop up is a diagram of the single island of a rodent, a mouse islet cell, which I will talk more about it. So it waited about 20 years later, in 1889, another German physician, Minkowski. Well, he comes from a very intelligent family. His brother, who's a physicist, is the teacher of Einstein. Anyway, he able to take out the pancreas of a dog without killing the dog. Voila! The dog becomes a diabetic instantly, and he dipped his finger in the dog's urine and tasted. Wow, it's really sweet. So from then on, he makes the connection between diabetes and the pancreas. There's something in the pancreas. Without that something, the dog becomes a diabetic. And that has been in the dreams of our Canadian Dr. Frederick Banting, so much he gave up his practice in medicine and went to University of Toronto with the help of a medical student, Charles Best, that you all know about, and who's the founder of a Canadian Diabetic Association. And also a biochemist, Dr. Collett from Alberta. They were able to extract insulin from this poor dog and inject it to a 14-year-old Leonard Thompson boy who was dying of diabetic ketoacidosis in the University Hospital of Toronto. So insulin was born. So that's why our tour, the first destination is the pancreas. You all know the pancreas is about the size of your palm. It tucked deep inside the tummy, behind the stomach, and encircled by this loop of bowel, which is the duodenum, and then is also next to the liver. The pancreas has two portions. The first one is the exocrine portion, meaning that it produces digestive enzymes and pass over to the gut for digestion. And the endocrine part is this islet cell that makes a lot of hormones. The islet cell makes more than just insulin. It also makes glucagon and 3 other hormones which provide fine-tuning of these 2 important hormones, glucagon and insulin. Now, the diagram on the right-hand side shows you that there's a lot of this yellow stained cell, which is the beta cell that makes insulin. In the rodent, it consists about 65 to 80% of this. And then 15 to 20% are those red cells, which is alpha cell that makes glucagon, which is on the rim of the ball. And then a few percent of the other cells too. So from this, we can understand. Normally, our blood sugar, if we are not eating before meals, is between 4 to 6. We all know. And after meal, it goes a little bit, but hopefully not more than 7.8, that we don't get complications. And in order to do that, it depends on the balance between insulin and glucagon. And let me say it again, glucagon is as important as insulin. The insulin works by delivering glucose into our cells. Now we know our post office, a postman deliver letter into a house. The postman is insulin, the letter is glucose, and the house is the cell. And it can be liver cell, muscle cell, fat cell, but not the brain. The brain doesn't need insulin. Then the glucagon that comes from the alpha cell would swim up to the liver and break down glycogen, which is a complex sugar, and increase the sugar, blood sugar, so there's a balance. So I follow this with the next slide. This is to show you that whenever our blood sugar is more than 4.5, the beta cell has a very unique sensor. It will start producing insulin. But if it drops below 4.5, it will stop. And the same thing applies to the alpha cell. When the blood sugar drops to below 3.8, glucagon will be produced. And you all know that it also produces the adrenal hormone, so that we are shaking and trembling and sweating and want to eat. But if we don't do anything, because this is a warning, and it drops down to below around 2, then our brain will be suffering and will be confused. And many a time I wonder how many car accidents is from the low blood sugar. And if we let it go down to below 1, will kill some of our brain cells. Insulin is a very ancient hormone. Not only dogs and cats and beef and pork or beef and pigs have insulin. The little animals or organisms like the little worm and the little fish, they have insulin. But in those lower animals, the insulin has a much more broader function. Not only it regulates sugar, amino acid and fat metabolism, it also helps the organism to grow like a growth hormone, and in addition to help them to produce babies. But in humans, being on the top of the evolutionary scale, we are able to specialize only using insulin for metabolism. There's a slightly little growth to it, maybe in the early part of our life, but definitely there's no reproductive function because we have estrogen and testosterone. This is to show you what an insulin looks like. It's made up of, on the left-hand picture, is a makeup of 2 chains, like a little beads of string of beads. You have an alpha and beta chain connected with 2 bridges. On the right-hand side is an insulin sculpture that my wife made it when she was in America. This is to show you in a day of 24 hours how we produce insulin. As I said earlier, whenever the glucose goes above 4.5, it starts producing insulin. So we're making insulin a little bit, maybe 1 unit an hour, that kind of thing, throughout the whole day. But if we eat our meal, breakfast, lunch, and dinner, then we need 5 to 10 times more insulin instantly to handle the flux of large amount of sugar coming into the liver and to the rest of the body. But this big push of insulin only lasts for a few hours and then will go back to normal. And let us go deeper into how the beta cells produce insulin. Now think about this. We have about 1 million islets, and each one has about 1,000 to 3,000 or 4,000 cells. So we have trillions and trillions of cells. If each one works independently and producing insulin on its own, it will be chaos. Just like the soldiers, they march, they have to synchronize. And in symphony, they have the conductor to conduct the coordinator. Then I have a question to all of you. Maybe some of you can answer the question. Who is the conductor? Number 2, when the beta cell produce insulin, they don't work like a water tap that you left unattended in the garden and drain all the water continuously. They are being produced in pulse. A burst of a little bit of insulin within 3 or 4 hours and then stop. And then it bursts. Now, this is very important because if we have continuous production, when we don't need it, we're wasting insulin, as well as having what we call, in medical term, down-regulating the insulin receptor. I'll talk about insulin receptor later, which means in simple terms, it devaluates the insulin. They're no longer as valuable, just like a Canadian dollar worth only 90 cents. The third interesting thing about insulin is, unlike all the other endocrine organs, all the other organs like your thyroid, your testes and pituitary, the adrenal gland, when they secrete the hormone, they quickly send it out to the bloodstream and scatter all over the body to use. But insulin is quite different. The beta cell makes insulin, all of them go up the vein, called the portal vein, into the liver. The liver is very selfish. It collects all the insulin from the cell. And for a very good reason, because the liver is bombarded with all the things that we eat. Sometimes we eat more than 3 meals, so you need a lot of insulin. So we need that to move the sugar into the cell. Then, as well, when either the beta cell makes insulin, as they come out of the islet cell, it touch on the alpha cell, which produce glucagon. Now, insulin instantly put a stop on the alpha cell. Don't make any glucagon. I don't need you because there's too much sugar in the blood. Now, when the insulin swim up to the liver, a lot of them being used, and inside the liver, interesting enough, there is an enzyme called insulinase that breaks down insulin. So that by the time what is left that come out of the liver to supply the rest of our body, which are mostly the muscles and the fat cell, only about 30-40% left. And the question is why? Now, before I do that, let us talk about insulin receptor. I have a cartoon here for you to look at. The circle there is the lining the wall of a cell. It can be a liver cell, a muscle cell, or a fat cell. And you see those on the left-hand side, there are doors. I call it doors. The yellow one, which is the insulin receptor. The blue one is the glucose channel, for a door for letting the glucose in. So when insulin swims through the blood in contact with the cell, it will touch on, not on the door, the yellow one. Hey, I'm coming. So that will send a message down to the cell, and the cell receives the message, will open the blue door and allow dots, which are the glucose, to come in, and then it will do something about it later. Then we should also know about what is insulin resistance. In fact, many of you are aware that type 2 diabetic patients, when they first started having the problem, nothing wrong with their pancreas. In fact, the pancreas works better than you and me if we are normal. It is because it started when they have insulin resistance, meaning that the insulin, the little yellow dot insulin, they become devaluated. They don't have the strength to knock at the door of the insulin receptor. Or that the insulin receptor the door becomes too old, too thick, they don't answer the knock. I've got a problem. Oh yeah, I'll go back to that. So then this becomes insulin resistance. So initially, when the patient has insulin resistance, they can make more insulin, but after a while, they're tired, less insulin being produced, they cannot produce 120%, then go down to 100, down to 80 and 50, of course, become a full-blown diabetic and need insulin to control the disease. So with all this understanding, we can now talk about the pitfall of insulin treatment. I'm sure quite a few of you may be on insulin, and I have to say that as a physician, a healthcare provider, we are totally frustrated. It's very difficult to regulate, to give just enough insulin that we don't get hypoglycemic and we don't gain weight. Because the way we give insulin is not physiological. we inject it subcutaneously under our skin in the tummy or legs and arms. This is a long way from the pancreas, a long way from the alpha cell. It cannot suppress the glucagon. And also it's a long way to swim up to the liver, because remember the insulin is coming from the beta cell, goes to the liver first, and for a very good reason. So end up we have to adjust our insulin so that when we wake up, our fasting glucose should be less than 7, if not 6. Then we'll have to pump a lot more insulin to satisfy the liver. At the same time, we're giving too much insulin for the rest of the body, that we gain weight and we lower our blood sugar quickly. And with gain weight, more fat and more insulin resistance. A vicious cycle, we call it. Now let us go to our second destination, which is the liver. I said earlier, the liver is a factory. It makes bile, cholesterol, clotting factor, name it, anything. It's a very busy place. That's why it needs a lot of energy, and the energy comes from the sugar. So that's why it has the first priority, first class, to receive all the sugar and fat and protein from the gut, which is the neighbor. And when the insulin goes to the liver, it will open the door and get the sugar into the liver cell. And one of the important functions of insulin is convert this glucose to a complex glucose called glycogen. Let me remind you that glycogen is such a big, compact sugar. Each molecule has about 150,000 glucose packed nicely together, and it's good for storage. Just like we have a compactor, and that is good for without too much room required. Now at the same time, glucagon work on the liver too, because the glucagons will break down this glycogen into glucose. And that's why some of you may have been given glucagon injection when your sugar goes down, because it instantly reverse the glucose back to normal without having to eat anything at all. And sometimes you are too sick to eat any. Our third destination is the fat cell. Now look at this fat cell. It's beautiful, but at the same time terrible. You see the blob of fat that balloon up the cell so that the cell is being squeezed to the side. The fat takes up about 98% of the volume of the cell and leaves very little. But the cell is quite happy because it is storage. Now, let me move on to what is the fat. Now, this fat is the one that I'm talking about is in your tummy. Of course, there's tummy fat in your buttock, under the skin, and this may be perhaps what we call brown fat or beta fat. The one in the tummy is really the problem. Now, what happens is when insulin swims to fat cell, each fat cell, the same thing, it attaches to the insulin receptor, knock on the door, then the fat cell knows the message to open up the door for the glucose to come in, but as well as receiving also free fatty acid, which is coming from our food, to come in. The free fatty acid, 3 of them packed together form a molecule called triglyceride, which is the molecule for storage. So insulin has a very important function to stop this triglyceride go back to free fatty acids. That's why when you're lack of insulin, you allow the fat cell in the tummy to liberate the free fatty acid, and they just swarm out and go right up to the liver. Of course, the liver loves it because, like glucose, is a raw material. The liver use that to make cholesterol, make bile, and from cholesterol we make a lot of hormones like the estrogen and testosterone, and we make a vitamin D as well. But if there's too much fat, we get fatty liver. Let me also mention that when too much fat is also spilled to the muscle, wrap up the muscle, the insulin couldn't get in, the glucose couldn't get in. This is insulin resistance, and when fat wrap up went into the islet cell, the pancreas. It poisoned the islet cell that makes less insulin, so they call lipid toxicity. Now let us look at the muscle. Well, this muscle is the biggest organ of our body. They has the most number of cells, and each one is able to use sugar for energy. So you can play soccer. Now, insulin, when it goes to the muscle, it does one thing very interesting. Insulin opens up the blood vessel. We call it vasodilator. And to do that is important because it floods the muscles with lots of blood, and therefore more sugar goes in. And when sugar goes in, it did the same thing. It does the same thing like the liver, convert them into glycogen, and it's the glycogen that allow us to go a 100-meter dash without having to rely on drinking any sugar. But of course, when you finish all the glycogen in the muscle, you burn fat. That's why you get fatigue and acidic, and you stop, exhausted. Now, while at this, I should talk about the habit of how doctors write prescriptions. I'm sure every doctor writes prescription, and if you are a patient, you receive them. But what is the largest number of prescriptions that I write every day? It is a prescription for exercise, not for pills or injection. Because exercise, you can increase the blood flow to the muscle 6 times by increasing the heart rate and increasing the blood pressure. And that will be able to flood the muscle with blood, more sugar, more fat into the muscle and burn it, so your tummy goes down. So my advice to my patient is, you do exercise 1 hour after your biggest meal. Because an hour after the meal, you would have all the last supply of sugar and fat in there, and if you mobilize them into the muscle instead into the tummy, then your game, you win the game. Then we swing over to the gut. When I was a young boy studying biology, I thought the gut is not very interesting because it's just 12 feet of intestine that digest and absorb food, but it's not so simple. Towards the end, the terminal 1 foot or so of the small intestine, at the junction when it connects almost to the appendix of the large bowel, the colon, that section of the small bowel makes a hormone called GLP-1. Actually, it's called glucagon-like peptide hormone, number 1. Now, this hormone, how it works like this. When we eat our food, it's been digested, and the food go down to the end of the small intestine, that's the time it stimulates the gut to make this hormone. Now, this hormone is very important. It has 4 important functions. The first one is the hormone will go by the bloodstream to the beta cell of the pancreas to stimulate, to augment, get the beta cell, in addition to the glucose, be able to get more insulin out. That at the same time, it will suppress the alpha cell, hey, don't make too much glucagon. And it also go to the stomach and tell the stomach, wait, slowly emptying your food. I remember in my younger days, my mother used to tell me, don't eat so fast. Bite your food and swallow it slowly. And she has a lot of physiological sense, because by chewing each mouthful of food 16 times, you are delaying the absorption of sugar into the blood, so that even if you have less insulin, you can handle it. It's easier to move 10 times up the stairs than 1 time 100 pounds. Then the 4th function is the brain. It also has either by email or by cell phone, communicate with the brain, hey, we have enough food, let us not eat more. So it decreases your desire for food. So if we have a pill or injection doing that, will be wonderful. Indeed we have. In 2008, since then we have 3 different tablets that can do the same, and we have 2 injections that could do the same. Our final destination is the kidney. The kidney, as I said, is a filter. Each kidney has 1 million of this filter. And on the right-hand side of the diagram, you can see the cut-off portion of the kidney. And also, this is also number 1, 2, 3, 4, 5, 6 is a portion of this filter. The filter has a ball, which is a number 5. Then it has a tube that goes down, looping, and go down and go up. And this tube is 4, 3, 2, 1. Now, what happens with the filter is the blood carried by the artery goes into the filter first and leaves the filter by the blue vein going back to the body. But during its passage through the filter, the big molecules will be retained, the small molecule will be filtered out, which is simple chemistry, simple physics. Like the big molecule are those hormones, cholesterol, clotting enzymes, all those proteins, albumin, and all this. They will be returned back to the circulation. But unfortunately, glucose is a tiny molecule made of 6 carbon. They are completely filtered into the tubule. And if you don't do anything about it, it will be leaked out in the urine. All is gone. We will be starved of glucose within a few hours. Problem, that section of the tube labeled as number 4, the first portion, has ability to reabsorb all the glucose that pass in until when the blood sugar goes beyond or higher than 10 millimole, then of course it's overcome its capacity, some urine will come out. So I remember in those days when I came to medical school, we have no way of checking no glucometer available unless we take a blood. We use dip a little stick into the urine. There's sugar in it. But that may be too late because there's a lot of sugar already. We know that in type 2 diabetes, especially, the body cells sense that there's not enough sugar coming to me. It sends a signal to the kidney, retain more sugar. So the kidney by that time will not lose any glucose unless your blood glucose go up to 13, 14, 15. So that way, of course, it's good for preserving sugar, but it's bad for us because it goes higher up. With this information, we can appreciate a new agent just came out last month in Canada, June 2014. This agent has been available in Europe and the States for more than a year now. The name of this agent is SGLT2 inhibitor. What does it mean? Now, SGLT2, S is sodium, G is glucose, and the P is the transporter. So this is the agent that blocks that segment of the tube, the first segment of the tube that reabsorbs glucose. That means would allow glucose filter at the filter, and pass out in the urine. So that even if your sugar is 4 or 5, 6, 7, you're still leaking sugar in the urine. Wow, it may not be very good when you look at it first. But think about this. You are losing glucose this way, so you lower the blood sugar without the need of more insulin, more diabetes, sulfonylurea, more DDP4 inhibitor, that kind of thing. And as well, when you lose sugar in the urine, sugar is calorie. You can lose as much as 600 calories a day, but simply do that. So there is another way of handling people with diabetes who have very high sugar, and you don't want to give them too much insulin or too much pill, and they are very heavy, overweight already. That's my catch. So far, there has been some incident of urinary tract infection. Imagine that you have a lot of sugar going through the urine, so those people, we have to tell them you have to have very good hygiene. In fact, if the patient do that, especially in ladies, when they have a smaller urethra, they should have a bidet built in their house, or do very good perineal hygiene to avoid that. Now, I've almost come to the end of our presentation and discussions. So as I said, we know the past, we understand the present. This is the time that we can predict the future. What do we want? What do we want to improve the treatment of diabetes in the next years to come? In my opinion, I would like to have smart insulin. The insulin has been very much improved now. But I like to have insulin that's targeted specifically for the liver, so that I inject insulin in under my tummy. It should not do anything until it reaches the liver, and then it becomes an active insulin and be able to work there, and the rest get out of the liver for the rest of the body, and we don't get so much of those complications, low blood sugar and weight gain. We also should have ultra-fast rapid insulin, instant. The one that we so-called rapid, it still cannot imitate what the beta cell is so instant. In fact, the beta cell, when you think about sugar, you can stimulate a little bit of insulin by a neural stimulation. Then now pumps is very, very handy to have, especially in the type 1. And we should have smart pump. Now, with the technology improved, the pumps are getting smaller and smaller. We now have pumps that don't need any needle, but it's a patch. You stick on the skin and you can go scuba diving with it, almost. And you can use your cell phone, your iPhone or Samsung to control the delivery of insulin into your body according to what you're going to eat. But more importantly, it's going to be available glucagon pump. The two work together. I have to say and emphasize again, we have neglected glucagon for many, many years. It is just as important as insulin. So I hope this will be maturing in very near future. Then another thing that I wish to have, my wish list so to speak, I like to have agents that target insulin resistance. People lose weight and be able to store fat efficiently, be able to burn fat. We take the fat into our cell. In each cell we have a mitochondria, which is the furnace, and we can speed up the furnace and burn the fat and keep us warm, and that will be nice. And of course, another wish I have is something to knock down the glucagon, to counteract glucagon. Don't get so much trouble. So another wish I have, and I read about this in April in the Journal of Diabetes, a cooperation between Beijing, China, and Atlanta, US. This group of scientists is coming up with an agent that comes from fungi in the rice. There's a molecule that can convert to be like insulin. This molecule is not a peptide, it's not a protein, so you can swallow it and be able to absorb it. And we will directly go into the cell and knock on this insulin receptor that may be coming. So with this, I want to end my presentation, and I hope you will be able to have some interesting dialogue, share your experience, your knowledge of about the internal organs related to diabetes. Thank you.
Thanks so much, Dr. Lau. So everyone, now this is an opportunity, if you have any questions for Dr. Lau from his presentation, just type away in the Q&A portion, and we will definitely try our best to get to all of them. Dr. Lau, we have a question from Jerry, and he wants to know what causes the damage to the nerves in the feet.
Well, the feet is supplied from the longest nerve of the body. It comes from a spinal cord, in the lumbar area, go into the tip of the toes. The longer the nerve, the more chance is being in a sugar bath. So if you don't look after diabetes, if you don't get your A1C in shape, so the sugar will be eating up those nerves, and you first started having this sensation of tingling, burning, and people ask, oh, I have to stick my feet out of the blanket at night because it's so hot. That this is an early sign of neuropathy. And if you don't pay attention at all, oh, all of a sudden oh, I don't have pain. I can step on fire and I can step on nail. It didn't hurt. Not a good thing because the nerve is dead. You have no sensation. I can share with you my one incident I have many years ago now, back in the 90s. I have a patient who went on an Alaska cruise, and when she arrived in Alaska, she found that she had a high fever. Went to see the ship captain, the ship doctor, only to find that he has a terrible the foot that is infected. And also the doctor found out there's a nail stuck to the bottom of her foot. Only to know that she was doing renovation of her house. She stepped on a nail, but with no sensation, she has no idea. So when she went up there in high fever, then she has to be flown back to Burnaby where we have to look after him. Oh, I see another question is called who?
Yes, who's the conductor?
Well, I have to guess, but this is something that I share with you. In our body, there are many, many cells. The cells have to talk to each other. And scientists quite a few years ago discovered that there's communication between the cell using a protein we call GAP protein, G-A-P, GAP protein. When I work in ICU at Burnaby Hospital for many years, I'm interested in the rhythm of the heart, and one of them is called atrial fibrillation that sometimes you know. Well, there's some people who have very early age of atrial fibrillation, and the reason they have it, they lost the GAP protein between the heart, the cells of the heart in the atrium, and that's where they get the atrial fibrillation, chaotic. Then in pancreas, there is a GAP protein called connexin 36, the organ number. 36 meaning the one that's found in the islet cell, 40 is the one that's found in the atrial cell. So when you lose this GAP protein, you don't coordinate. So the conductor is a GAP protein called connexin, C-O-N-N-E-X-I-N, 36. That's the conductor.
And Lillian wants to know, she sees some people with type 1 diabetes who have very bad rashes on their legs. What's the cause for that?
Well, there's many causes because number one, the organs it's simple. You have too much sugar in the blood, and you have you don't have the sensation to protect it, and you don't look after it, and you allow the infection to go in, so that healing to create the first a rash and then an infection, and depends on also your sweating maybe not very good, and to protect yourself to flush off all the dirt. So there's a variety of reasons for that.
Okay. And another question from Jerry, why does it take so long to heal when you have neuropathy and you have the wound?
It's not only neuropathy that diabetic has. Very often they come at the same time. They also have vasculopathy, meaning the small blood vessels are rotten. To have a good healing, you have to deliver nutrient, oxygen into the to the area of infection. And when you don't have that, you don't your white blood cell has to go there to fight the battle. And when you don't have that, your wound healing will be delayed.
Okay, and from Elaine, I have reduced my A1C from 7.5 to 6.3, and now it's 5.8. My doctor doesn't want me to have a lower A1C than 5.8. Could you explain why, please?
I wish all my patients are like you. That's a good achievement from that. Now, we do know the A1C in the past, in the previous guideline of the CD8 is if you get below 7 is not too bad. Now we like it to go down to 6.5 and will be better because our ophthalmologist colleague have discovered that people, even with a low A1C like 6.5 to 7, they may still have very early retinopathy because they have some microvascular complication. So it's preferable to get down to the lower reading as low as you can afford it, meaning that without getting the side effect of the treatment, which is low blood sugar and weight gain. So there is a balance between the two. One of the things that hurt me and many other physicians is we are too much glucose-centric, meaning that we focus our brain and a target only on sugar and forget everything else. But we should also look at the fat. If you get the sugar down good, your A1C down to 0, but you gain 20 pounds, actually you're killing yourself. So I don't know how old this lady is, but of course if a young kid, they have another 80, 90 years of lifespan, they should have the A1C as low as possible. But in my 80 plus elderly patient, I would even let them live with a A1C of 8. You take years to develop the microvascular complication, and if you at the same time treat the blood pressure, treat the cholesterol, get the good diet, a little bit of exercise, is far better than playing with a figure from 8.5 down to 0.8, that kind of thing.
Okay, so it's very dependent on the age. Okay, can Dr. Lau make any comments about the future of stem cell research as it might relate to a cure for type 1?
It's hopeful, but stem cell has, in my opinion, is a more problem. You can, number one, make the stem cell efficiently at very low cost. Now we do understand that a way of reprogram a normal cell like the cells scraped from the skin to become stem cell is possible. Technology is possible. So this is one thing. The next thing is, okay, you make the stem cell, but you know how to control it. We do know one of the reasons why we are difficult to get rid of cancer is many chemotherapy, radiation, killing cancer cells that are not stem cell. The stem cell of the cancer has stem cell too, and it is the stem cell that perpetuates the problem. So it's not a panacea that, oh, I got stem cell, I can make any cell I like. It's now simple. And I think, in my mind, the best thing to do is if you have an artificial pancreas.
Okay, from Maria, as opposed to type 1 diabetes where beta cell loss is autoimmune, what causes lack of insulin and pancreatic cell loss, which is also present in type 2 diabetes?
Type 2 diabetes is from many, many different factors, much more complicated. But by and large, the present date of the explosion of a number of people with type 2 diabetes is because of the change of lifestyle. And we can see that happen again in Canada. Immigrants from other places where they didn't have diabetes, within 5 years they become diabetic because they eat a different way at home and back in their home, and they work a lot harder. So by and large, type 2 diabetes is started with insulin resistance. The insulin they have devalued. Initially, their islets are even stronger than a normal person. They make 10, 120, 130% more, but only for a few years. Eventually, the islet cell exhausted and they go downstream. And when you are telling the islet cell to work super normal, then they will make mistakes of making some other things like amyloid. Amyloid is another protein that the beta cells secrete, and the amyloid is like Alzheimer's disease and those things that can poison the cell and the premature death of the islet cell. Eventually, by the time when the patient diagnosed with type 2 diabetes, actually they have only about 50% of the function of the islet cell.
And Dr. Lau, a follow-up to a previous question from Elaine. David wants to know, what does A1C actually stand for?
Well, it's hemoglobin A1C. When we measure hemoglobin A1C, we have to take blood from the arm. And we are not measuring the blood sugar. We are measuring the blood in the red blood cell. Now remember, we have millions of red blood cells running in our body to deliver oxygen. They're very busy, they're very active. They need energy, which is sugar. They get the sugar, glucose from the blood. So if today your sugar is 10, oh, not good. The red blood cell love it because they suck 10 units of sugar into the cells for use. But if tomorrow you are very good and you don't overeat and exercise it down to about 5, then tomorrow all the red blood cells will have only the 5 units to come in. Now, we know that red blood cell lifespan is about 120 days. When you take blood from my arm right now, I have a number of red blood cells just born. And I have also those about to die, different ages. And if I measure all their sugar, that means I know the average. So if my A1C, hemoglobin A1C today is 6.5, that means today is July the 16th. That means for the month of June, May, and April, my average is 6.5.
And Elaine wanted you to know, you're wondering how old she was when she was asking about AC1. She's 69 years old.
Well, then I would, well, I'm not, well, I'm just like you, we are old, but not that old. And I would not drive the A1C. Of course, if you can get it down even 0.1, 0.2, 0.3 lower is better. But as I say, at what cost? So you have to balance between the two.
And Donna wants to know why a sport such as squash, why does it elevate blood sugar versus a long run, which tends to lower blood sugar?
Sorry, I didn't get that. Repeat that again.
She just wants to know why a sport, like a high-intensity sport like squash, tends to elevate blood sugar, whereas a long run tends to lower blood sugar.
I'm not quite sure the gist of the why low blood. Say that again. I'm sorry. I didn't get the meaning of the question.
Is there a reason why? Let's say I went for a 2-hour long run.
Yeah.
That lower my blood sugar.
Oh, because you use up all the you see the muscle running, you need energy. It sucks all the glucose to burn the glucose. Or initially, the muscle has glycogen, the complex sugar. It breaks down and supplied, so that will lower the will suck. Then also they would suck more blood into the muscle. When your heart goes faster, your blood pressure goes. So the muscle will suck 6 times more blood in, and therefore 6 times or even more use up so much sugar, so your blood sugar will go down. Definitely. That's why the people on insulin, you'll be very careful. You have to make sure that you have enough glucose during your run or during your sport, and pre-check your sugar even before doing your going on a run.
Okay. So a follow-up question to that from Iris. She says when she exercises, it seems her blood glucose always goes up. Why is that?
That depends on the timing. Because when you are running, and as soon as you stop running, you check your sugar, it may be up for very shortly, but eventually it will come down. The reason is when you're running, you stimulate not only glucagon, but you stimulate adrenaline from the adrenal gland. The adrenaline will quickly go to the liver and dump a lot of sugar, break down on the glycogen, and then temporarily during that transitional zone, you may have a little higher sugar. But don't you worry, because you will be coming down eventually for the rest of the day. It will be lower than what it should be. It's a timing.
Okay, so it's all in the timing. And Michelle is asking, is it fair to say retinopathy is also related to vasculopathy like neuropathy?
Absolutely. In fact, when we look at, when you talk about complication of diabetes, we have 2 types. One is microvascular complication. One is macro. Micro is those that destroy the retina, the tiny little capillary vessels, and they destroy the nerve, and they destroy the kidney. So this is microvasculopathy. And we do know that sugar has a biggest player in causing this type of disease. whereas macrovascular disease contributed by high glucose, of course, but another two important player is blood pressure and cholesterol or fat.
And Jesse wants to know, could you say something about the future possibility of stem cell transplants to regenerate the functioning of B cells in the pancreas?
I thought we discussed it earlier. Let me repeat
I think
it.
it's just a follow-up. I think he just had a follow-up question. He seems to be really interested in stem cell transplants.
A stem cell transplant to regenerate function of, yeah. Well, the main thing that I assume that you want to know if we can use your own cell, reprogram it to be stem cell, and then inject it into your body, that you don't reject it, then this possibility. Now, I don't know how long, when it will happen, and I hope this will mature.
Okay. So we don't have any more questions at the moment. But Dr. Lau, is there something, you gave us so much information tonight. I learned a lot. Is there something you would like people to take away from your presentation? If there's one or two things, what would it be?
My conclusion is don't hope for a miracle drug injection that can cure diabetes. Not yet. I think if I want to do that within my lifetime and look at myself, I can share with you, in 1997, I discovered my fasting glucose was 6.8 and had a scare. And from then on, my interest in diabetes took a quantum leap, and I want to know everything that can preserve my islet cells. Now, as of last month, my A1C is still 6.5. My fasting glucose did go up contrary to 7.1. And that's the reason I've been taking 500 milligrams of metformin every night. But in my case, throughout these years, I changed my lifestyle. I gave up driving to work. I took a train and I walked up a steep hill in West Vancouver for 20 minutes to get home. And I can tell you, I can lower my blood sugar. Now, if I have a bowl of noodle, which being Chinese, I just love them. And 2 hours later, I can hit the blood sugar of 8.9. It's very scary. But if I have the same bowl of noodle, I walk down to Marine Drive in West Vancouver and walk up a steep hill, I can get it down to 5.4. And it's paramount to me that we need to improve our lifestyle. 100 years ago, I'm sure there wasn't that many type 2 diabetes.
So you just made a lifestyle change, like a simple lifestyle change, like walking to work, and you've noticed a big difference?
No, you have to do some more. Just an example, you do walk, exercise after meal. There's another way of conquering that. And so you try to release, get rid of the insulin resistance. And for the time being, there are very few medication can do that. There was a big hope. I almost took that pill called Evendia quite 10 years ago. That's a target on insulin resistance. Very successful, I have to say. But then the side effect is there.
I have a couple more questions coming in. Iris says all her life, her feet have always felt hot, even in the winter. Is there maybe a reason for this? She also says, and because she loves to walk barefoot, her feet have decreased sensation on the soles.
Well, I wouldn't advise you to wear barefoot. I wouldn't advise anybody wear barefoot because we don't know what we are stepping on. If you're diabetic, it's even worse because your healing mechanism is decreased and your sense of pain may be decreased and you don't look after that. Now, hot feet, the simple explanation is some people are very lucky. they have a capillary dilatation, meaning that the small blood vessel open up more quicker and more efficiently, deliver more warmth to the tip of the foot. But then, on the other hand, there may be an early warning of neuropathy because that may upset the balance of the blood vessel that they don't know how to constrict to preserve heat, and whereas it dilate the opposite way. So it's on both. You have to look into the both sides, and you have to discuss with the doctor and be examined and find out what's the cause.
Okay, and Jerry wants to know, why can't the pancreas be transplanted?
No, the pancreas can be transplanted. Technically, it's not a big problem, except that after just like any transplantation, you transplant an organ, but they don't live because it's coming from somebody else. The body has a very good way of rejecting it. And that's why in 2001, the Edmonton Protocol, University of Edmonton was shocking the whole world. They discovered a way of transplanting islet cells, not pancreas, not the whole pancreas. They get from the donor. They collected all the little islet cells that I showed you, the islet Langerhans, and packed them together, cleaned them up, and injected into the portal vein directly going to the liver, and the islet cells stay in the liver and start making insulin. That's a perfect place. But unfortunately, they don't last. After a year or 2 or 3, most of the cells die. And of course, there's a problem is also it's very difficult to get the donors.
Yeah, of course. And Michelle has a good question here. SGLT2 inhibitors are so new in Canada. You said they've been in use for England for a year. Do you think there's a long enough safety data for them?
Well, it's been used in Europe, not in England, and the States for a year. Actually, it's a very interesting molecule. It comes from the apple tree's bark. In the bark there, in fact, years ago, the people know that there's something there. When you pick it, it can poison your kidney so that you pass sugar. But the scientists are now good enough to modify that molecule that is safe enough to be used. So far, of course, any new drug, we have short-term safety. They've been studied for a few years. They started with mice, and then in the clinical trial in the patients, of thousands of them, there's always a fear that there's some unknown side effect that surface years later. So it's, as I say, that don't depend on a magic cure of a new pill. And I would be willing to use that kind of medicine in selected patients, especially those who are 300 pounds.
Okay. And Patty says she's a type 2 diabetic and uses insulin, but her doctor also gave her glycoside to lower her blood level. Is that a good plan too? And I probably mispronounced that. I'm sorry.
Yeah. So I would say yes and no. If you have a good doctor, he's focused on getting your hemoglobin A1C down, and you probably at the stage when your islet cell is making not enough insulin, so you have to use reluctantly insulin to do the additional job. But also, I suspect that your islet cell is still making some, and as long as the islet cell is making some, you should use it, because the insulin coming from the islet cell is much better than the one to inject in the tummy. So he would use this glycoside, which is sulfonylurea. But unfortunately, when you take glycoside, you have to be careful. Glycoside is an agent that has been used, the same kind of agent, since 1954. This agent has a very powerful effect of putting a squeeze on your pancreas or the islet cell and shooting insulin out. But regardless whether your blood sugar is high or low, it will be continuous coming out. It's good that you have very little function of the islet cell, so it doesn't matter. So the little bit comes. But in people in the early stage of diabetic patient, when they use this pill, they may get very low blood sugar without any help, because you are not eating, you eat less, you exercise, you don't need the insulin, but the glycoside is squeezing your islet cell, keep on putting out insulin, so you have a low insulin. That's why in 2008 came out this GLP-1 pills and injection. They won't do that. So this is one of the safety factors. So you are doing the right thing, the insulin plus a pill to do that, because in order to avoid having too big a dose of insulin.
Okay, well that wraps up the questions for tonight and the presentation. Dr. Lau, thank you so much for your time. I know you pulled double duty because you first gave a presentation in Chinese tonight, so it's been a busy evening for you.
Well, I hope I did a better job having a little training process.
It was great. And I'd also like to thank everyone who attended the webinar tonight, and of course for all of the amazing volunteers who coordinated this session. We would like to remind everyone that you will be sent an evaluation survey tomorrow, and of course we encourage you to complete it. And it should only take a couple minutes and provide very valuable input for our association. And we talked about this a little bit last time about the Diabetes Charter. And the Charter is a grassroots initiative to empower the diabetes community. And you can check out all about that on www.mydiabetiescharter.ca if you want to learn more about that. The development and delivery of impactful programs such as our new Canadian Diabetes webinar series is made possible through generous support of our donors. If you enjoyed the webinar and would like to make a donation, please visit our website at www.diabetes.ca or call 1-800-BANTING. Thank you for your support, everyone, and thank you for participating in tonight's webinar. It was very informative. Thank you again, Dr. Lau.
It's a pleasure.
Take care. Bye.